Hi, my name is Elisa Chauca, and my tutor is John Moscoso. I'm studying in the University Católica Santiago de Guayaquil. And let's go to talk about Rivoxaban in patients with heart failure, sinus, ring, and coronary disease. Definition. Rivoxaban is an oral direct factor XA inhibitor that reduces thrombin generation. The treatment improved outcomes for patients with worsening chronic heart failure and coronary artery disease. Since heart failure is associated with activation of thrombin-related pathways, which predicts a poor prognosis. And video.
So in this chapter, Chapter 6, Cardiology, we'll be specifically focusing on our anticoagulants. The 4 different groups of anticoagulants that will be focused in this video are going to be our unfractionated heparin, commonly just referred to as heparin, our low molecular weight heparin, and an example of that is our enoxaparin. That's the generic, and the brand name is Lovenox. Then we have our vitamin K antagonist, commonly known as warfarin, and one of the brand names for that is Coumadin. And then last we have our factor 10A inhibitor, and an example of that is going to be Rivoxaban, the brand name for that, Xarelto. So for our first practice question, we have a blood thinning medication that does not require renal adjustments and has a rapid onset of action. Is that A, our unfractionated heparin, B, our low molecular weight heparin, enoxaparin, brand name Lovenox, C, our vitamin K antagonist, warfarin, brand name Coumadin, or D, our factor 10A inhibitor, Rivoxaban, brand name Xarelto. That's going to be A, heparin. So no renal adjustments are necessary with heparin, and this does have a rapid onset of action. So our enoxaparin and our Rivoxaban are both going to need renal adjustments, and specifically our Rivoxaban, or our 10A inhibitor, is going to be contraindicated in patients that have severe renal dysfunction. Both warfarin and heparin do not require renal adjustments. However, warfarin has a delayed onset of action, and it can take several days until it can reach its maximum effects. So that is why A is correct in this question. The next question is focusing on our low molecular weight heparin, enoxaparin. So which of the following medications can be taken at home and is administered via injection? So again, that's going to be our enoxaparin, or our low molecular weight heparin. So heparin itself is not used outpatient. It's just used in the inpatient setting while it is still an injection. Then we have our enoxaparin, which is an injection that's administered subcutaneously, and it can be used outpatient. Warfarin and Rivoxaban, while they're both used outpatient, they are only oral formulations. Then we are talking about warfarin on this specific slide. So which medication interacts with green leafy vegetables and requires the most monitoring? So our green leafy vegetables are going to contain a lot of vitamin K. And vitamin K is going to help our blood clot. So specifically, warfarin works to decrease our vitamin K factors, specifically 2, 7, 9, and 10. So warfarin in this case is going to interact with a lot of our green leafy vegetables. And it's not that patients can't have these green leafy vegetables. It's just that we want to make sure that they're keeping the amounts that they have from week to week consistent. Also, warfarin, out of the list of medications here, does have the highest risk of bleeding, so therefore it does require the most monitoring. Specifically with warfarin, we monitor something called an INR, or an international normalized ratio, and essentially that measures to see if our blood is too thick or too thin. So It's going to depend on what we're treating for the patient, but typically our range is going to be anywhere from 2 to 3 or 2.5 to 3.5. So anything that's going to be lower than 2.5 or lower than 2 is going to mean that our blood is going to be a little bit too thick, and anything higher than 3 or 3.5 is going to mean that our blood is a little bit too thin and increases our risk of bleeding. Our heparin does require some moderate monitoring when we use our APTT to monitor our heparin, and then our enoxaparin and our Rivoxaban are a little bit safer medications and don't require as much monitoring as they possess the least risk of bleeding. Then our last question here, we have which medication requires monitoring of renal function and is preferred in patients who have an aversion to needles. So again, we have 2 different medications on this list that do require monitoring of renal function, and that's going to be our enoxaparin, or our low molecular weight heparin, and our factor Xa inhibitor, specifically our Rivoxaban. So we can cross out our heparin and our warfarin, as those can be used in patients that do have some renal dysfunction. But as we previously mentioned, our enoxaparin is going to be an injectable form, so that might be something that we would want to avoid in patients that might have an aversion to needles. So Rivoxaban, while it does require monitoring of renal function, it is an oral formulation medication, so that would be a good option for this patient.
Applications in nursing. The variety of indications include 1. The treatment and prevention of venous thromboembolism. 2. The prevention of stroke or systemic embolism in patients with atrial fibrillation. Low dose of Rivoxaban in combination with antiplatelet agents. Rivoxaban, more antiplatelet, reduce the risk of death from cardiovascular cause, myocardial infarction, and stroke in patients with acute coronary syndromes or stable coronary artery disease. And the video.
In this lecture, we're going to cover anticoagulants and antiplatelet agents. So let's get right into it. Anticoagulants and antiplatelet agents are used to treat thrombotic disorders, or unwanted clot inside a blood vessel, which can lead to heart attack or stroke. But before we discuss their mechanism of action, let's quickly review the clotting process. So in the absence of injury, the endothelial cells that make up the inner surface of blood vessels release chemical mediators, such as nitric oxide and prostacyclin. Now, nitric oxide's job is to dilate blood vessels, while prostacyclin's job is to bind to receptors located on platelets. This binding triggers certain reactions which ultimately prevent platelet activation and aggregation. Now, what happens when there is a damaged blood vessel? Let's say due to skin cut. Well, suddenly, we have less nitric oxide and prostacyclin around, so blood vessels become constricted and platelets become activated. But first thing first, with the help of von Willebrand factors, platelets adhere to exposed collagen, which in turn causes them to change shape. Next, these activated, differently shaped platelets begin to release granules containing chemical mediators, such as ADP, thrombin, thromboxane A2, serotonin, and platelet activating factor, which attract and activate even more platelets that come to the site of injury. Now, the final step involves activation of the glycoprotein 2B3A receptors, which bind circulating fibrinogen. The fibrinogen simultaneously binds to these receptors on 2 separate platelets, thus cross-linking platelets to form aggregates. Now, there are several drugs that can disrupt this platelet plaque formation. Collectively, we call them platelet aggregation inhibitors, or simply antiplatelet drugs. One of the most widely known drugs that belongs to this class is aspirin. In order to understand how aspirin works, let's take a closer look at the inside of a platelet. So when platelet becomes activated, arachidonic acid is released from the membrane phospholipids. Then it gets converted to prostaglandin H2 by cyclooxygenase 1 enzyme, also known as COX-1. Finally, prostaglandin H2 is further metabolized to thromboxane A2, which is released from the platelet to stimulate activation of new platelets as well as promote their aggregation. So what aspirin does is it irreversibly inactivates COX-1 enzyme, thus effectively disrupting clot formation. Next, we have platelet aggregation inhibitors that work by blocking the action of ADP receptor, specifically P2Y12 subtype. Drugs that belong to this group include clopidogrel, ticagrelor, ticlopidine, and prasugrel. As I mentioned before, activated platelets release chemical mediators. One of them is ADP, which binds to P2Y12 receptor, leading to activation of the glycoprotein 2B3A receptors, which are required for fibrin-mediated platelet cross-linking. So by blocking P2Y12 ADP receptors, these drugs effectively inhibit platelet aggregation and thus clot formation. Next, we have glycoprotein 2B3A receptor blockers, namely abciximab, eptifibatide, and tirofiban. These agents simply inhibit platelet aggregation by binding to the glycoprotein 2B3A receptors on platelets, thus preventing fibrinogen from binding to platelets and making them unable to cross-link. Unlike the other drugs that we discussed so far, glycoprotein 2B3A inhibitors are administered only intravenously. Now, the last group of antiplatelets drugs that I wanted to briefly discuss are phosphodiesterase inhibitors, namely dipyridamole and cilostazol. These two agents inhibit enzyme called phosphodiesterase that is responsible for breaking down cyclic AMP to AMP. So by blocking this enzyme, dipyridamole and cilostazol increase intracellular levels of cyclic AMP, which in turn leads to decrease in intracellular calcium and ultimately inhibition of platelet activation. Furthermore, these agents inhibit phosphodiesterase in the vascular wall as well as uptake of adenosine, which promotes vasodilation. For that reason, cilostazol in particular is often used to treat symptoms of peripheral artery disease, such as narrowing of vessels that supply blood to legs. When it comes to side effects, bleeding is a major risk associated with all antiplatelet drugs. Additionally, dipyridamole and cilostazol, due to their vasodilating properties, can produce headaches. Now let's go back to our review of clot formation. So the aggregation of platelets acting like a plaque is usually not enough to secure the site of injury. In order to strengthen the platelet plaque, a clot must form. The formation of clot involves a cascade of enzyme reactions that transform various clotting factors to their active forms, ultimately producing web-like fibrin mesh. Now there are two pathways involved with the clotting cascade. The intrinsic pathway, which is activated by damage directly to the blood vessel wall, and extrinsic pathway, which is activated by trauma to the vascular wall as well as surrounding tissue. So the intrinsic pathway starts with clotting factor 12, which is activated when blood comes into contact with the collagen in the damaged vascular wall. And here, A next to the Roman numeral stands for activated. This sets a series of reactions that leads to activation of factor 11, which then activates factor 9, which then activates factor 10. Activated factor 10 then converts prothrombin to thrombin. And finally, thrombin converts fibrinogen to fibrin, which forms mesh that strengthens the platelet plaque. Now let's take a look at the extrinsic pathway. So extrinsic pathway is triggered by tissue factor released from damaged cells outside the circulating blood. It starts with the activation of factor 7, which then activates factor 10. So at this point, the intrinsic and extrinsic pathway converge into a common pathway, which again results in formation of fibrin clot. And as a side note here, keep in mind that this is just a simplified description of coagulation cascade and many details were intentionally omitted. So now let's switch gears and let's talk about anticoagulants, that is, drugs that work by disrupting this coagulation cascade. And let's begin by discussing one of the most widely recognized anticoagulants, that is, heparin and low molecular weight heparins, such as enoxaparin and dalteparin. Now, these agents bind to our natural anticoagulant circulating in blood called antithrombin 3. The primary function of antithrombin is to inactivate factor Xa and thrombin. So what heparin drugs do is they bind to antithrombin, and by doing so, they accelerate its activity. In case of heparin, its binding to antithrombin results in rapid inactivation of both factor Xa and thrombin. However, unlike heparin, low molecular weight heparins have very little effect on inactivation of thrombin, and instead they selectively accelerate inactivation of factor Xa. Another agent worth mentioning here that also selectively accelerates inactivation of factor Xa is fondaparinux. However, unlike low molecular weight heparins, fondaparinux doesn't bind to any other plasma proteins and has no direct effect on thrombin. When it comes to side effects, bleeding is a major risk. Fortunately, there is a reversal agent called protamine sulfate, which can be used to treat excessive bleeding caused by heparin drugs. Protamine sulfate simply works by binding to heparin or low molecular weight heparins to form stable inactive complex. Fondaparinux, on the other hand, doesn't have any specific antidote at this time. Another possible major side effect that is particularly associated with the use of heparin agents is heparin-induced thrombocytopenia, HIT for short. HIT is a disorder caused by immune system making antibodies to heparin when it's bound to platelet-derived protein called platelet factor 4. Once the antibodies bind to these heparin platelet factor 4 complexes, they begin to activate platelets which clump together, causing formation of unwanted clots and fall in platelet count. Now, let's move on to another group of anticoagulants, that is, direct inhibitors of factor Xa. Agents that belong to this group are apixaban and rivaroxaban. The mechanism of action of these drugs is very simple. They both bind directly to the active site of factor Xa, thus preventing it from converting prothrombin to thrombin. The biggest advantage of these agents over the other anticoagulants that we discussed is that they are available in oral formulation. Unfortunately, bleeding is still a major risk and specific antidote is currently not available. Now, let's move on to the next group of anticoagulants, that is, direct thrombin inhibitors. Now, depending on how they interact with the thrombin molecule, agents in this group can be subdivided into two classes. First, we have univalent direct thrombin inhibitors, which bind only to the active site. Examples of drugs that belong to this class are argatroban and dabigatran. The second class are bivalent direct thrombin inhibitors, which bind to both the active site and the exoside 1, that is fibrinogen binding site. This bivalent binding contributes to their high affinity and high specificity for thrombin. Examples of drugs that belong to this class are bivalirudin and decirutin. Now, one of the biggest advantages of direct thrombin inhibitors over indirect thrombin inhibitors such as heparin is that they don't bind to platelet factor 4, which makes them very useful in treatment of heparin-induced thrombocytopenia. However, just like with other anticoagulants, bleeding is a major risk and there is no specific antidote available at this time. Now, there is one more anticoagulant that I wanted to discuss, which is warfarin. Warfarin is one of the oldest anticoagulants that's still on the market, and it has its own unique mechanism of action. Now, in order to understand how warfarin works, it's important to first understand the role of vitamin K in the coagulation cascade. So, vitamin K is required for synthesis of factors 2, 7, 9, and 10. These coagulation factors are biologically inactive until they are carboxylated by vitamin K. This carboxylation reaction proceeds when we have reduced form of vitamin K available. In this reaction, reduced vitamin K is oxidized to the vitamin K epoxide in the presence of oxygen and carbon dioxide, yielding carboxylated, fully active clotting factors. In the last step of this reaction, oxidized vitamin K is recycled back to the reduced form by an enzyme called vitamin K epoxide reductase. This is where warfarin comes into play, as it inhibits this enzyme and thus disrupts this vitamin K dependent synthesis of biologically active clotting factors as well as some other regulatory factors. Now, one of the biggest disadvantages of warfarin is that it has a narrow therapeutic window and has been associated with many drug-drug and drug-food interactions. For these reasons, clinicians need to closely monitor patients on warfarin by using the International Normalized Ratio measurements, also known as INR, and adjust the dose when necessary to balance the risk of bleeding against the risk of clotting. Fortunately, in the event of bleeding, anticoagulant effects of warfarin can be overcome by administration of vitamin K. However, reversal can take up to 24 hours. Therefore, in the event of emergency, infusion of fresh frozen plasma might be necessary. Now, the last group of drugs that I wanted to discuss in this lecture are thrombolytics. While antiplatelets and anticoagulants prevent the clot from getting formed in the first place, thrombolytics act on the existing clot, causing it to dissolve. And the way they do this is by directly or indirectly activating circulating protein called plasminogen, which then turns into plasmin. Now, plasmin is an enzyme that breaks cross-links between fibrin molecules, thereby dissolving the clot. Examples of thrombolytics include alteplase, reteplase, and tenecteplase, which are produced by recombinant DNA technology to mimic our naturally occurring tissue plasminogen activator. Another example is an agent called urokinase, which is a naturally occurring thrombolytic produced from cultured human kidney cells. And lastly, we have an agent called streptokinase, which is derived from streptococcal bacteria. Now, one of the main differences between these agents is their selectivity for fibrin-bound plasminogen versus free circulating plasminogen. So while tissue plasminogen activator such as alteplase is more clot selective and acts to dissolve the fibrin in the thrombus, streptokinase and urokinase are less clot selective and thus are more likely to cause internal bleeding into any organ system. These bleeding complications from thrombolytic therapy can be managed by administration of aminocaproic acid or tranexamic acid. These two agents can stop fibrinolysis by inhibiting binding of plasminogen to fibrin as well as conversion of plasminogen to plasmin. And with that, I wanted to thank you for watching. I hope you enjoyed this lecture, and as always, stay tuned for more.
Is applied in Ecuador. In Ecuador, the main limitation of the administration of Rivoxaban is the cost, which is why studies were conducted demonstrating the cost effectiveness of using this drug compared with the traditional treatment of warfarin. Pros and cons. Pros: facilitates adherence to treatment. It isn't contraindicated in severe renal failure. Doesn't require adjustment for age. Dyspepsia doesn't increase. Shortest half-life. Tendency to reduce AMI. Cons: anemia, nausea. uncommon, syncope, tachycardia, drug interactions, aspirin. And the video.
Good evening. Welcome to Heart. I'm Dave Spector. With me again tonight, Dr. Andy Waxler from Burke's Cardiologists. Tonight we're going to talk about anticoagulants. Probably the most common one is Coumadin.
Coumadin.
That's what everyone knows. Explain, I know there's a bunch more out. We've talked about them in passing. Why, what do they do, and what are the precautions that people have to take when they are taking them? I know there are some foods or juices or whatever that if people are on certain anticoagulants they got to be careful about taking or whatever. First off, what are they?
Fair enough. First of all, Dave, thanks for having me on as usual. Good to see you. It's a good fall, except that both of our teams are out.
That's true, but mine made it a little bit further.
One game further. I have to say that I'm a diehard Phillies fan. This guy's a diehard Braves fan, and sadly, both of our teams are sayonara. It's end of chipper. But anyway, when we talk about blood thinners, Dave, I think it's important that our viewers understand, without getting too much detail, and I don't want to put anybody to sleep, but the short version of a complicated story is there's actually two types of ways that your body can form blood clots. Now remember, Dave, blood clots are good if you need them. Let me give you for instance. 1,000,000 years ago, when our forefathers, ancestors were running away from a dinosaur and they tripped and scraped their knee. Or nowadays, when we shave, and you shave a little bit, Dave.
Yeah, a little bit.
Dave's got a full beard. He doesn't shave a whole lot. But when I shave and when Dave shaves a little bit, if you cut yourself and you're bleeding, it's helpful to have a system in your body that forms blood clots, or we would all be dead immediately. I think everybody in the viewing world understands that you have to have some system to clot, or you would die. We would all bleed to death. So clotting is good as long as there's a little bit of clotting. Our bodies are very sophisticated that we actually have two different systems to form blood clots. Without making this too complicated, suffice it to say there's one system that uses things called platelets. Platelets are these little things that float around your blood, and they can form blood clots. And they tend to form blood clots in arteries. So when people have a heart attack, it's usually a blood clot inside an artery, and you want to use a medicine that will inhibit platelets. We're not going to spend a lot of time about that tonight. Maybe we'll talk about that next time, Dave. But things that inhibit platelets are simple aspirin. And then there's these three super aspirins. I call them super aspirins, Dave. One is called Plavix, which has been around about 14 or 15 years, since like 1997 or 98. I remember the day that came out. And then in the last 2 years, there's been a second one called Effient and a third one called Brilinta. Plavix, Effient, Brilinta, all they are is super aspirin, and these things inhibit platelets. They're very helpful in people that have had a heart attack or are having a heart attack, because platelets work mostly in arteries. But Dave, there's a second system that causes blood clots, and this second system uses something called clotting factors. Clotting factors tend to cause blood clots more in veins and in large areas of the body. So when people get a blood clot in the veins of their leg, maybe several of you out there either yourself have had a blood clot in your vein of your leg, or maybe you know somebody, those can travel up to the lungs. That's more caused by the other system, the clotting factors. Also, people can get blood clots inside their heart. And actually, we could show, if you show a slide number, I think it's number 3, would show a blood clot inside the heart. That's also formed by clotting factors. Well, that's actually atrial fibrillation, and that's an arrhythmia that we've talked about in the past. And if you go to the next slide, people with atrial fibrillation can get these blood clots. There we go. Awesome. So that sort of shows up a little bit, but that is a picture of what's called the left atrial appendage, Dave. That's the upper part of the heart, the left upper chamber. There's like a little piece there where people can get a blood clot there. And that's caused by the clotting factors that we just talked about. And these clotting factors, which can cause blood clots inside the heart itself or in veins of the body, like the veins of the legs, you need to go on a medicine to try to prevent those types of things. And those medicines, the number one, the granddaddy of them all, is called Coumadin. And the generic for Coumadin is warfarin. So I gave you a long answer to a short question, Dave, but yes, the sort of the number one quote, I'm going to use the word, I'm going to use quotes, blood thinner that we all have known about for all of our lifetimes just about is Coumadin. Dave, did you know how warfarin was invented? Warfarin is the generic name.
No.
Warfarin, it's really cool. Warfarin, W-A-R-F-I-N, warfarin, comes from the Wisconsin Area Research Foundation, WARF, W-A-R-F. It was invented in University of Wisconsin in about the 1930s because farmers in the 19-teens and the 1920s noticed that if their cows would eat rotting hay, rotting cloves and hay, they would actually bleed to death. And so people said, what the heck? Why are these cows bleeding to death? And they looked into this rotting hay and they found that there was this blood thinner chemical, which people at University of Wisconsin figured out what it was, and they actually turned it into a medicine called warfarin. And again, the generic is named warfarin. The brand name is called Coumadin. DuPont, the company DuPont, made a lot of money, I think, in the 50s and 60s and 70s on Coumadin. And do you know one of the first human beings, Dave, to be on Coumadin? President Eisenhower. Dwight Eisenhower was on Coumadin in the mid-1950s. So Coumadin's been around literally like 60 years. It's an old drug. But you mentioned a couple of negatives about it, Dave. It's a pain in the neck. Patients hate it. Patients hate Coumadin for a lot of reasons.
We've talked about they have to be checked every month or so?
At least every month. So the thing about Coumadin is different than almost every other drug, right? Most drugs, a doctor knows, oh, you need to be on 100 milligrams twice a day or 50 milligrams twice a day. There's sort of a dose. Coumadin, there's like a dose range. Like we know that most people need somewhere between about maybe 2 milligrams of Coumadin a day up to about 10 milligrams of Coumadin. But everybody's different. In other words, the Coumadin dose that would work for you, Dave, might be different than would work for me. And you can't predict looking at big people. People think, oh, if he's a big, husky guy, he needs a bigger dose. If it's a skinny, elderly lady, she needs a little dose. That doesn't always fit. Logic doesn't always fit. And the only way you know the dose is by checking blood tests. So as you've already mentioned, the first negative about Coumadin is it's a pain in the neck because you have to get frequent blood tests. And the way it works is very simple. We get a blood test, and if your blood is too thin, we tell you to cut back the dose. Remember, Coumadin's a blood thinner.
Okay, now you said 2 to 10 milligrams. So you're going to give them a bottle of 100 2-milligram tablets?
No, we start with the most, you're not that far off. The most commonly prescribed dose of Coumadin is 5. Okay, probably I'm going to guess 95% of people who are on Coumadin have 5 milligram tablets at home. That's just what we usually use. So what we do is we start them on 5 milligrams a day, and we tell them to get a blood test in 3 or 4 days, or maybe 5 days. And if the Coumadin level is high, we say, ooh, we better cut back. If the Coumadin level is low, we say, ooh, we need to increase it. Nobody said this is rocket science, Dave. I mean, honest to gosh, this is not that hard.
So you starts with 5s.
And you kind of adjust.
And you adjust him up to 8. Well,
literally.
Now, is he going to get an 8-milligram tablet or 2 4s?
No, we would do 7.5. We would say take 1.5
Oh,
See?
so now he's got to cut these little...
Well, no, you can snap them, you can break them in half. But honest to gosh, I'm not making this up. So
No, I
this is
believe
how
you.
doctors have been doing Coumadin literally for 60 years. I'm not making this up. And so once you make an adjustment of the dose, you bring the person back 4, 5, 6 days later to recheck the blood test, and the whole process starts over again. Now, eventually, the patient gets on kind of a regular dose, and then you can say maybe stretch them out to 2 weeks or 3 weeks, and ultimately to 1 month. So the standard of care is once you get a person on the right dose of Coumadin, why then you can usually do them once a month. So then it becomes a little bit less of a pain in the neck. But patients hate it. They're always getting blood tests, and then they have to find out.
And the blood test isn't done at your office. He's got to go to the lab.
Funny you should say that. Until about, I don't know, 6, 7 years ago, about 6 or 7 years ago, patients would have to go to a lab, get the big needle in their, what we call the antecubital fossa, right here, and then they'd get a phone call maybe 6 hours later from the office. But then inevitably we would make a phone call and the person wouldn't be home, and then it's a pain in the neck. So about 5, 6, 7 years ago, people started inventing these finger stick Coumadin, actually could have been 10 years ago, these finger stick Coumadin clinics where you can go to a doctor's office and we give you a scheduled time. It's like an appointment. So, you say, come at 2:15. We have nurses that just prick your finger. It's almost like what the diabetics do.
Like the ones they're showing on TV for diabetics now.
It's the same thing. So you just prick your finger, they put the drop of blood down, and honest to gosh, in like 3 minutes, you know the result. The nurse tells you, because we have all these charts. And by the way, the doctors have to sign off on the charts every day. So right then and there, the nurse is following the charts, but within a couple of hours, me or one of the other guys is looking at just to kind of supervise. And that is the standard of care. We're not doing anything sneaky. That's how it's done. So the patient gets instant feedback within literally, I'm not making this up, within 5 minutes. They say, oh, your Coumadin level looks good. We'll see you back in 2 weeks. Or your Coumadin level's a little high. Let's cut you back from, say, 5 milligrams a day to sometimes we'll do 5 alternating with 2.5. So you make adjustments.
5 one day, 2.5 the next, 5.
Something like that. Everybody's different. Now, so the other negative, that's one negative of Coumadin. The other negative of Coumadin is there's a lot of stuff out there that makes the Coumadin level go up, like antibiotics. So what happens is we'll have a patient on Coumadin, and then they'll get like an upper respiratory tract infection, like a bronchitis. Excuse me. I was acting it out, and now I think I've got a stuffy nose. And they'll go to their family doctor, and the family doctor does the right thing, puts them on antibiotics. Some antibiotics make the Coumadin level go crazy. So then we see the person a week later, and we say, oh my gosh, well, your blood is so thin. So we tell all our patients are really well educated. Any other medication, particularly antibiotics, but any other medications, you let us know. Now, there are some some foods that actually do the opposite. Green leafy vegetables, broccoli, spinach, the stuff that kids don't like to eat.
The healthy stuff that they're pushing now.
The good foods, they actually make the Coumadin level go down. They actually work as an antidote for the Coumadin. So you can imagine a scenario where patients get really frustrated because they have to really be on their toes to look for antibiotics and look for foods. So that's sort of part of the pain in the neck of Coumadin.
We'll take a break. We'll be back in 30 seconds.
You're watching Heart to Heart on bctv.org. Be informed, be involved, be a member. For membership information, go to www.bctv.org/support/membership. For other information about heart health and fitness, go to bctv.org. Heart to Heart is underwritten by Berk's Cardiologists. Program underwriting is a valuable source of revenue for bctv.org. For more information on how you and your business can become program underwriters, go to bctv.org.
Hey, thank you very much. Just a reminder, Oktoberfest, BCTV's big fundraiser, October 22nd to 27th, live on-air auction, Monday Merchant Monday, Tuesday Rec and Leisure, 24th Wednesday Dining Out and Entertainment, Thursday the 25th Gallery of Crafts, Friday the 26th Sports and Collectibles, and Saturday the 27th starting at 2 o'clock, Friends of BCTV. There's all the information you need Reminder, we're live tonight, 610-378-0426. Any questions about strokes, heart disease, heart attacks, whatever. Food interaction with Coumadin, food juice, etc. Anything they've got to worry about. We started talking about green leafy vegetables.
Right. Green leafy vegetables lowers the Coumadin level. By the way, there's a blood test called the INR. I like Isaac, N like Nancy, R like Reading Royals. So the INR level is a blood test that we've used for the last 10 or 15 years to actually measure the thinness of the blood. It's very simple. The higher the INR, the more thin your blood. The lower the INR, the more thick your blood. And there's a range. And for different blood clotting conditions that we're trying to treat, there's a different range. For one called atrial fibrillation, which is where the heart's out of rhythm, and that can lead to a blood clot in the heart and cause a stroke, the standard of care is to aim for an INR between 2.0 and 3.0. For some mechanical metal heart valves, Dave, there are sometimes people who have these metal heart valves. Those must have blood thinner, and the INR must be, it's usually 2.5 to 3.5, so a little bit thicker, or pardon me, oh my gosh, a little bit thinner. But people get a blood clot in their leg, what we call a DVT, or a blood clot that travels to their lungs, what we call a PE. Again, the goal is 2.0 to 3.0. So I just named 3 reasons. There's about 4 or 5 reasons to be on Coumadin, and it's a life-saving medicine. But basically, one other question for you, Dave, trivia question. Do you know what Coumadin was initially used for, before it was used for a medicine?
No idea.
It's a rat poison. So Coumadin is actually rat poison. It's not called Coumadin, but it's the same thing, because it thins the blood, and we don't really measure the INR on the rats. We just give them a lot of it. So Coumadin is the ultimate double-edged sword in medicine. Double-edged sword is something that can help you but hurt you. Coumadin is a life-saving medication. If your doctor says you need to be on Coumadin, you should go on Coumadin, because if you have one of these conditions, you could die if you're not on Coumadin. So it's very important. On the other hand, you have to be very careful because it can do harm. So it is a double-edged sword.
Home viewer, welcome. What can we do for you tonight?
Yeah, my question is, why not just use foods that thin the blood and have healthy, wonderful side effects rather than using Coumadin?
That's an interesting question. There aren't really any foods that thin the blood, number one. And number two, there's no way to monitor it, because these conditions that need Coumadin are life-threatening conditions, or if not life-threatening, can cause major bad things like big strokes. And you can't take the chance of having fluctuations. So a couple reasons. You need the consistency of thinness of the blood, and number two, medications don't really thin the blood. Pardon me, food doesn't really thin the blood. It's more they interact with Coumadin.
I'm pretty sure that some foods do thin the blood, like garlic, like green leafy vegetables. They do have an effect of thinning the blood.
No, green leafy vegetables actually is an antidote to Coumadin. It actually counteracts the Coumadin blood thinning ability. So green leafy vegetables are actually the opposite. Garlic may thin the blood a little bit, but I don't want to give you a hard time, but what I'm saying to you is you can't adjust the food to a certain thinness to save your life. This is not for everybody. These are for people with major bad conditions that are either going to have a big stroke or die. You know what I mean? There really is no sort of food option here.
Yeah, and I just read a recent study about the use of pomegranate juice in this major study, and that it brought about, in the 1 year, a 30% decrease in the plaque in the arteries of people who have, heart disease.
That's a completely different subject. That's a completely different subject.
So you might want to check into that. Isn't that amazing?
Yeah. But believe me, I'm all for natural things, okay? I'm not against you. I agree with you. Believe me, I'm very open-minded, and I encourage my patients to take fish oil, to eat a handful of nuts every day, things, sort of natural things that have been shown to be beneficial, but not in this case. If people have major life-threatening conditions that need a blood thinner, they are risking their life by trying to do a natural alternative. I mean, a natural alternative for these conditions, they're going to get a natural result, and stroke and heart attack and death are very natural. So this is not a good time to do a natural alternative, in my humble opinion.
Okay.
But I do agree with you in general, though. if that makes
No,
sense.
no, I know. I really appreciate your show too. By the way.
Thank you.
Yeah.
Thanks for calling in.
You sound like a regular, so you know that we push and try and keep away from medications only as a last resort. Really,
We're not closed-minded. We're certainly open to natural things, but the situations we're talking about today, you're going to get in trouble by trying to do it naturally.
Okay. Thank you very much.
You're very welcome. Thanks for calling.
what you're saying is the green leafy vegetables interact with the Coumadin.
Right.
They don't interact really with the existing state of things.
Correct. They more act like an antidote to the Coumadin.
Right. In other words, they're not going to affect the thinness of the blood by themselves, but they will negatively affect how the Coumadin is affecting.
Exactly.
Okay.
I would agree with that statement.
Okay.
So let's go to the next slide. And so Coumadin really, to thin the blood for things in the veins, again, blood clots in the vein of the leg, what we call DVT, or blood clots inside the heart, what can come from atrial fibrillation and cause a stroke, or metal valves, for, again, I've mentioned for 60 years, literally since Eisenhower was president, I'm not exaggerating, Coumadin has been the standard of care with all the negatives that we just talked about. And again, Coumadin, warfarin's the generic name. I've been a doctor for 20 years. For 20 years, I've been listening to patients complain about how much they hate Coumadin, and they wish there was they wish there were an alternative. Well, for 20 years, I've been hearing pharmaceutical companies tell us that they have something on the horizon. Funny enough, Dave, about 2 years ago, one called Pradaxa came out, and that's why I have this slide out here to show Pradaxa. That was about 2 years ago. And then about a year ago, a second one came out called Xarelto. There is a third one that's the FDA is reviewing that I'm sure will be out within the next couple of months. I forgot the name of it. But there is going to be a third agent out there that's sort of like a newer alternative to Coumadin. And again, the two that are out there are Pradaxa and Xarelto, and there's going to be a third one. Now, what are these agents? These are agents that work like Coumadin. They thin the blood in veins and inside the heart, but not so much in the arteries. So again, if a person has a platelet problem in the arteries causing a heart attack, that's where they need things like aspirin. So, but if a person has blood clot that comes from atrial fibrillation, where they had been on Coumadin for years, now they could be on Pradaxa or Xarelto. The thing about Pradaxa and Xarelto is they've only been FDA approved for use with patients with atrial fibrillation. We've talked about atrial fibrillation in the past, Dave. That's an irregular heart rhythm where the two top chambers of the heart are out of sync. They're out of rhythm. And I tell people that the two upper chambers of the heart look like an English muffin, in nooks and crannies. And so people get blood clots in those little nooks and crannies, and those blood clots can then fly off and cause bad things to happen, like a stroke. So that's why with atrial fibrillation you need to be on a blood thinner so you don't get blood clots in the nooks and crannies. And we've been using Coumadin for 60 years. For the last 2 years, Dave, we have Pradaxa and Xarelto. There's a couple advantages to Pradaxa and Xarelto. Can I tell you the advantages?
Tell me the advantages. One is they don't have to have blood tests as often.
That's the biggest advantage. So the biggest advantage,
that.
Dave knows his stuff. You are correct. The biggest advantage of Pradaxa and Xarelto is there's one dose. Well, that's not true. In Pradaxa, they actually came out with 2 doses. But for 99% of the world, there's basically one dose. And you don't need blood tests. We don't need to individualize it. I would say to you, Mr. Spector, because I wouldn't call you by your first name, Mr. Spector, you have this condition called atrial fibrillation. You're at risk for getting blood clots up in those nooks and crannies, and you could have a stroke. You need to go on a blood thinner. And we would talk about Coumadin, and then you would say, well, I don't want Coumadin because I like to eat green leafy vegetables and I don't like blood tests. Well, Dave, excuse me, Mr. Spector, we've got this new thing called Pradaxa or Xarelto. It will do the same thing as Coumadin, and there are studies that show that it is as good, if not better, than Coumadin. Pradaxa and Coumadin have been compared head-to-head. Xarelto and Coumadin have been compared head-to-head. It's as good, if not better. And you don't need blood tests. So you're not giving up any effectiveness, and you're not getting the blood tests. That's a major advantage. Here's the disadvantage. It ain't generic, which means it's new, which means it's brand name. Now, both companies that make, one company that makes Pradaxa, one company that makes Xarelto, both companies have tried to negotiate with these drug companies, these insurance plans, so it's like tier 2. I don't really understand all these things. I know there's like tier 1, tier 2, tier 3. Tier 2, they tell me, is usually about 30 or 40 bucks a month. Out of your pocket, these things could be literally like 100 bucks a month. But I think that if you have an insurance plan, you could probably get it for 30 or 40 bucks a month, and there's all kinds of little discounts. So there's a financial issue. There's only one other negative to Pradaxa and Xarelto, and that is there are no antidotes. There is an antidote to Coumadin. Let's say, God forbid...
What do you mean by antidotes?
Well, for Coumadin, there are medicines that we can give a person in an emergency department that will reverse the Coumadin. What if you're on a blood thinner, Dave, Mr. Spector? If you're my patient, I would say, Mr. Spector, what would you do if you were in a car accident and God forbid you had internal bleeding? Coumadin does have antidotes. Now, granted, the antidotes take a few hours. It's still not a good thing. It's not good. We tell people on Coumadin, make sure you wear your seatbelt. Don't play professional football, Mr. Spector. Your football career's got to end. So you got to do things. You know, you really probably shouldn't be skiing and things. You shouldn't be putting yourself at risk for trauma. Now, we all drive a car, but you should probably be cautious. Now, these newer agents don't have any antidote. When I complain to the companies, what am I supposed to do? Their answer is, yeah, but they wear off within about 24 hours. Coumadin, Coumadin does have an antidote. It probably takes 6 to 12 hours to work. So that's not a bowl of cherries either. It's not great. So these Pradaxa and Xarelto, I got to tell you, some patients love them. Some patients love them because they hate the blood tests and they hate having to worry about what they're eating and what else they're taking. So these are easier. These medicines are easier as long as you understand that it's a brand name and that there's no antidote. But I got to tell you, certain patients have really thrived on these new medicines. But it's an individual thing. The doctor and the patient have to have a conversation. And so that's the story on these new blood thinners. It's very interesting. It's kind of exciting that we have options. We like options. We doctors like to give patients options.
Well, it gives them a choice, especially if they are, like the gentleman who called us, concerned about their health and are eating healthy with green leafy vegetables that you can't tell. If they're on Coumadin and they're having green leafy vegetables, they're probably going to be getting a blood test every week.
Right. I do tell patients who are on Coumadin that like their green leafy vegetables, as long as you eat them, A, in moderation, and B, consistently. In other words, people on Coumadin who like green leafy vegetables, where you get into trouble is if you don't eat any for 2 weeks and then you, for 3 days, just, go crazy with broccoli and spinach.
So if they're having spinach, kale, broccoli every other day, regular basis, they're okay.
Right.
You can control it.
Because we adjust around it. In other words, remember I said these green leafy vegetables work as a partial antidote. So we just crank up the dose a little bit. So the problem is when they stop eating the green leafy vegetables, so you just have to be consistency. But these new medicines, they seem to work for certain patients. Every patient's individual. You can only use these new medicines for atrial fibrillation. So if you have a blood clot in your vein or a mechanical metal valve, got to be on Coumadin. And that's important.
We got to run.
We're out of
they
time
flashed
already.
us twice, Andy. Thanks. Thank you very much. We'll see you all in December. Don't forget Oktoberfest in 2 weeks. Call and buy. Thanks.
Have a nice autumn.
Conclusion. Rivoxaban at a dose of 2.5 mg twice daily was not associated with a significantly lower rate of deep myocardial infarction or stroke than placebo among patients with worsening coronary heart failure, reduced left ventricular ejection fraction, coronary artery disease, and no atrial fibrillation. And the video.
Whether they are called novel oral anticoagulants or, as they're trying to move to now in the U.S. and in many cases, direct oral anticoagulants, they are certainly still a hot topic at meetings such as the American Heart Association. And I'm talking with Conchetta Crivera, who is a PharmD and an MPH and a director within Janssen. And we're talking costs here. There's a presentation at this meeting, and we're talking about costs of Rivoxaban compared to warfarin, correct?
That's correct.
So this is a pretty large study, what, 4,500 patients?
Yeah, we looked at 4,500 patients using the Humana database, which includes commercial and Medicare insurance members, and we looked longitudinally. These are new start Rivoxaban patients, and we took a look at longitudinally at their total cost of care, which we feel is really a contribution to the literature because of the fact that recently published Rivoxaban data has really just shown about the hospital costs, kind of isolating that.
Right.
But what we decided to do was look at the total cost, include the cost of warfarin, which is pennies, include the cost of Rivoxaban, and really take a look at what's the total overall cost when you look holistically at outpatient, inpatient, ER, and then the pharmacy costs.
And what did you find?
We found that when you include the pharmacy costs, we actually found when you're looking at all cause and AF related, that it's comparable between Riva and warfarin. So that is really the take-home message, and very exciting when we're comparing an agent which is a newer factor 10A oral anticoagulant compared to a generic warfarin.
So what is this going to tell us in terms of more widespread use? For a while there was a concern that it wasn't being adopted fast enough, these new agents weren't being adopted fast enough in the United States. Now it does look like they're starting to move, correct?
Yeah, so there's been misconceptions that, warfarin, the pennies a day, but what we really need to, and this study shows us in the real world setting, looking at hospital pharmacy claims, medical claims, across the spectrum of patients, that you really need to take the entire healthcare landscape. You should really look at hospital costs. You should look at outpatient visits, because it all makes a contribution at the end into the total overall cost of care.
So what else are you going to be doing? Are you following this up and doing more analyses?
Well, yeah, so Janssen is really, we're going to be publishing this data, and we have a commitment to real world effectiveness, real world data, looking at these claims databases and really bringing forth research questions on the economics and studying of these drugs.
Well, for all of the last couple of years, we've been talking so much about costs, and so it's really nice to hear some positive news and some encouraging news about one of the newer agents.
Yeah, we're very exciting, and this is a contribution to the literature.
Yeah, absolutely. Now, we have a variety of coverage from CardioSource World News and the American Heart Association meeting, so please look for our cover story and other videos here at YouTube and across JAG.
Thank you.